Hey, what's up you guys? Today we will be talking about skin infections. So skin infections, we'll be discussing erysipelas, and we'll talk about cellulitis. Cellulitis could be outpatient or it could be inpatient. We're going to talk about that. And we're going to talk about severe cellulitis, or what we call necrotizing fasciitis, and we'll talk about osteomyelitis. Okay. So erysipelas, what do we do usually? Usually you can draw lines on the pen, so you can, it's usually well demarcated erythema, and well demarcated, so that's the main thing. Hot, red and tender, hot, red, tender skin. Okay, so we treat it as same thing as a cellulitis. So cellulitis outpatient management, usually if it's either could be strip or a staph. Okay, if it's a strip, we can start cephalexin or amoxicillin. But if it's staph, then we can start dicloxacillin or clindamycin. Okay, so this is for strip, this is for staph. Inpatient, how do you manage it? If it is strip, you give ceftriaxone or ampicillin. If it's a staph, then you give vancomycin or clindamycin. Okay, and again, the difference between erysipelas and cellulitis, usually this is fast, let's say fast, hot, red, tender, well demarcated. Okay, while erysipelas, insidious and less obvious. Insidious, less obvious. The other thing that I want to mention is that, let me just move that here. With the inpatient criteria, when do we admit inpatient? When do we admit? When there is sepsis, the criteria for SIRS, failure of outpatient antibiotics, and inability to tolerate PO antibiotics. So this need to be in your documentation for the insurance to approve that you are right by admitting this patient. Okay, so you gotta make sure you know that. What is the differentiate staph from strep? Usually staph usually associated with the blisters. Okay, bullae, abscess. Okay, but strep less likely to be associated with that. And pay attention, look for distractors. Pay attention, rule out distractors. Okay, there are distractors. For example, stasis dermatitis. I saw a case like that a few days ago. DVT could be thrombophlebitis. These are the distractors. So make sure it's not one of these, because these don't need antibiotics, but these does. Okay, so now this is the regular cellulitis. What if it is a necrotizing fasciitis? What is it? What is that? This is very important. Patient will be very sick, and usually you said purple, black, blisters, crepitus, extreme pain, anesthesia. And then what do we do after that? We find these things. You do broad spectrum antibiotics. broad spectrum antibiotics. For example, we do Vanco plus Peptazo, okay, Piperacillin, Tazobactam. After that, we can do imaging, X-ray, and then even we can consider MRI, CT scan, and then operate early. This is important, okay? So you do early surgical consults. They may need that for the thing, and you modify antibiotic based on the biopsy. So if it's Vibrio vulnificus, could cause a very severe cellulitis, then we do ceftriaxone plus doxycycline. Could be strep biogen, we continue the same thing. If it's C. difficile, we add clindamycin. Okay, so these are the management for the severe cellulitis. For osteomyelitis, could be two things, okay? Could be non-toxic, or it could be toxic, right? So for the non-toxic, what is usually patient present? Bone pain, chronic, stubborn wound, okay, recurrent cellulitis, okay? So these are the things. What do? We diagnose them with X-ray. We do X-ray. If the X-ray is positive, then we do bone biopsy. If it's the X-ray, if it's positive, then we can do bone biopsy before antibiotic, not blood culture. This is bone biopsy, not a blood culture, because it's in the bone, you know. If the X-ray negative, then we can go for MRI or CT scan, okay? And then after that, once we confirm that it is cellulitis, we do a treatment, usually 4 to 6 weeks of antibiotic, and wait for culture results. No empiric here, okay? That's very important. And then you follow up. The way you follow up with ESR, C-reactive protein, weekly. So you just follow how the inflammation going. No empiric, that's the keyword here. Very important. What if it's toxic, hematogenous, or vertebral? Okay, usually they have back pain, fever, plus there's IV drug abuse history, and plus it could be suspected Staph aureus. This is dangerous bug. How do you manage that? You do first, after that you do X-ray. If the X-ray is positive, okay, then you don't need to do imaging. You do blood culture because it's toxic, plus bone culture, bone biopsy, okay? But if the X-ray negative, is the same thing. X-ray, if it's negative, then we do MRI or CT scan. And regarding the management, what do? This is gonna get more interesting. So let's see. What do we do with the management? So the treatment, wait for culture, okay, and blood culture is fine. If you find something, blood culture is okay. And then the other thing, no empiric treatment unless one of these things, very toxic, or there's a neurologic dysfunction, or there's epidural abscess. Epidural abscess. So these are the things where we treat empirically, okay? So that's basically a summary for skin or bone infections. So just to summarize, If it's a cellulitis, usually or erysipelas, if the outpatient, you just cephaloxin and amoxicillin. If it's strep, dicloxacillin, clindamycin if it's staph. If it's inpatient, ceftriaxone, ampicillin if it's strep, vancomycin, clindamycin if it's staph. If it is necrotizing fasciitis, first we do broad vancopeptazo, and then you do imaging biopsy, and then based on the biopsy, if it's Vibrio, you add ceftriaxone doxy. If it's C. difficile, clindamycin, or if it's Clostridium gangrene or whatever. If it is osteomyelitis, could be non-toxic or toxic. Non-toxic usually bone pain, chronic, recurrent. Toxic is the back pain, fever, IV drug abuse, and Staph aureus. The non-toxic, in both of them, we start with X-ray. If it's positive, in the non-toxic, we do bone biopsy before antibiotic, and no need for blood culture. But if it's toxic, we do both blood culture and bone culture. And we wait for the blood culture, and then we start 4 to 6 weeks of antibiotics. And you follow up with the SRC-reactive protein weekly. We wait for the culture for both, unless there is very toxic symptoms, neurologic dysfunction, or epidural abscess. And that's basically a summary of skin infections. Thank you so much for listening.